Hello everybody. So in part 1, I discussed clinical overview, history and physical assessment in diarrhea. Today I will discuss investigation and treatment. So let's start. So just to recap first, in most adults, diarrhea is transient and caused by virus. So it resolves with hydration and supportive care. Understanding this natural course prevents overtreatment and unwarranted anxiety. The art of practice lies in selective testing, knowing when to act and when to observe. Severe or prolonged illness, bloody diarrhea, and vulnerable hosts justify stool testing, and when indicated, empiric therapy should be started. The final message is one of hierarchy. Hydration first, restoring physiology, antibiotics selectively, targeting proven or likely pathogens, and prevention always through hygiene, safe food, and surveillance. Now I will proceed to investigation and treatment of diarrhea. So next slide. So first is stool testing. When should we do it? Stool testing should be done when there is frequent, profuse diarrhea, typically 6 or more unformed stools per day. Severe illness implies hemodynamic instability, high fever, or severe abdominal pain. In such settings, stool culture or multiplex molecular testing may identify bacterial pathogens. Mild self-limited cases rarely benefit. The combination of bloody or mucoid stools with high fever is an indication for colonic inflammation. These patients require stool testing to identify invasive bacteria like Shigella, Salmonella, or Campylobacter, Clostridium difficile, or protozoa such as Entamoeba histolytica. Certain populations merit testing even relatively mild disease because their outcomes are disproportionately severe. Older adults are vulnerable to dehydration and ischemic complications. Pregnant women face unique risk from Listeria or Salmonella, and immunocompromised patients, whether due to HIV, chemotherapy, or transplantation, may have unusual pathogens like cytomegalovirus, microsporidia, or cryptosporidium. Now, stool culture. Routine stool culture primarily screens for 3 pathogens: Salmonella, Shigella, and Campylobacter. They represent most bacterial causes of invasive diarrhea. Culture remains the gold standard for confirmatory diagnosis. But molecular panels detect more organisms, culture isolates viable bacteria, and you can trace any outbreak epidemiologically. Many enteric bacteria require special media or culture conditions. Vibrio needs thiosulfate citrate bile sucrose agar. Yersinia grows at cooler temperatures. Listeria requires enrichment media. So you must tell the laboratory about these suspicions. Otherwise, they are easily overlooked. Positive stool cultures are significant just not for the individual patient. Reporting allows public health authorities to track outbreaks, and susceptibility testing identifies emerging resistant organisms. So, clinicians should ensure that isolates are forwarded to reference laboratories when indicated. Now, a little bit about multiplex PCR panels. Multiplex PCR panels have changed the total scenario of enteric diagnostics because now we can detect 15 to 25 pathogens simultaneously within hours. They are particularly useful when the differential diagnoses are broad or multiple organisms might coexist. However, detection of microbial DNA or RNA does not necessarily mean active infection. Some assays pick up non-viable organisms or asymptomatic carriers. So, result must be interpreted in the context. PCR detects genetic material, not viability. This distinction is critical when interpreting the results. After recent infections or antibiotic exposure, residual nucleic acid may persist for days to weeks, yielding false positive interpretations. Similarly, identifying multiple pathogens in one specimen is common and should not prompt indiscriminate polytherapy. Even when PCR identifies a bacterial pathogen, confirmatory culture remains essential for antimicrobial susceptibility and public health reporting. Many institutions now employ reflex culture protocols, automatically culturing PCR positive specimen to retrieve viable isolates. This hybrid approach merges molecular speed with traditional microbiologic depth. So clinicians should confirm whether their local laboratory performs such reflex testing. If not, they should request culture explicitly when bacterial infection is suspected. Now about bloody diarrhea. Visibly bloody diarrhea requires urgent differentiation between Shiga toxin producing Escherichia coli and other invasive causes. Stool should be tested for Shiga toxin via immunoassay or PCR, as antibiotics in Shiga toxin and Escherichia coli increase the risk of hemolytic uremic syndrome. Fecal leukocytes or lactoferrin suggest colonic inflammation but are non-specific. The clinician's role is to ensure the correct sample, fresh, unformed stool, is obtained promptly and the laboratory is alerted to the suspicion. Timely toxin testing prevents inappropriate antibiotic use and facilitates early recognition of potential hemolytic uremic syndrome development. When bloody diarrhea arises in returning travelers or men who have sex with men, Entamoeba histolytica must be considered. This protozoan can cause colitis, which is indistinguishable from bacterial dysentery, but requires metronidazole or such medication, not standard bacterial therapy. The absence of fecal leukocytes despite blood is a useful clue as Entamoeba histolytica lyses white cells. Diagnosis rests on antigen detection or PCR. Since microscopy cannot reliably distinguish pathogenic Entamoeba histolytica from non-pathogenic Entamoeba diaspora. Not all bloody diarrhea is infectious. When stool studies are negative or systemic illness is absent, non-infectious causes like inflammatory bowel disease or ischemic colitis must be explored. Colonoscopy should be done once the patient is stabilized, but it can reveal mucosal ulceration, patterns characteristic of Crohn's disease, ulcerative colitis, or ischemia. In older adults with vascular risk factors, ischemic colitis often presents abruptly after hypotension or dehydration. So differentiating these entities avoids misdirected antibiotics and allows appropriate anti-inflammatory or supportive management. Now, persistent or chronic diarrhea, we shall discuss about in detail later on. But when diarrhea extends beyond 2 weeks, the probability of bacterial or viral infection is reduced, and you should suspect protozoal or non-infectious causes. Giardia, Cryptosporidium, Cyclospora, and Entamoeba are key infectious culprits, especially with travel or contaminated water exposure. Yet, persistent diarrhea may also reflect post-infectious functional syndromes, inflammatory bowel disease, or malabsorption. Persistence should always trigger reassessment. Protozoal shedding is intermittent, so 3 separate stool specimens collected 24 to 48 hours apart are recommended for ova and parasites microscopy. Laboratories should be alerted if Cryptosporidium or Cyclospora is suspected, as these require modified stains. The key message for trainees is simple. A single negative ova and parasite does not exclude parasitic infection. Sampling strategy matters as much as test choice. Consider Entamoeba histolytica, Giardia, Cryptosporidium, and Cyclospora. These 4 organisms account for most infectious causes of persistent diarrhea. Entamoeba histolytica causes invasive dysentery and hepatic abscess and many other complications. Giardia produces malabsorption with steatorrhea and bloating. Cryptosporidium is self-limited in immunocompetent hosts, but chronic in AIDS and other immunocompromised patients. Cyclospora causes relapsing watery diarrhea linked to imported foods. Now about special populations. In any patient with recent antibiotic exposure or hospitalization within 3 months, Clostridium difficile should be in the first differential. Symptoms range from mild diarrhea to pseudomembranous colitis and toxic megacolon. Remember, even benign antibiotics like amoxicillin or proton pump inhibitors can precipitate Clostridium difficile infection. In immunocompromised individuals, solid organ or stem cell transplant recipients, advanced HIV infection or chemotherapy patients, common pathogens coexist with opportunistic infections. Cytomegalovirus colitis presents with fever, abdominal pain, and hematophagia, and often requires endoscopic biopsy with histopathology or immunohistochemistry for definitive diagnosis. Microsporidia and isospora infections cause chronic watery diarrhea diagnosed by specialized stains or PCR. So you can understand recognizing immune status changes the diagnostic algorithm. In patients with HIV and CD4 T lymphocytes less than 50 per microliter, cytomegalovirus colitis must be ruled out if diarrhea is severe, bloody, or unresponsive to empiric therapy. Other opportunistic pathogens like Mycobacterium avium complex, Cryptosporidium, Microsporidium can also coexist. Now, a little bit about outbreak and public health. So, timely reporting of clusters, two or more cases linked by time, place, or exposure is essential for outbreak containment. Clinicians are often the first detectors of sentinel cases. Whether it's foodborne salmonella, waterborne giardia, or viral gastroenteritis in a facility, early notification to local public health authorities enables source tracing, testing of food, water samples, and prevention of further spread. Waterborne outbreaks typically involve these pathogens. So diagnostic panels should include antigen or PCR testing for Giardia and Cryptosporidium and RT-PCR for norovirus because these agents resist routine chlorination and outbreaks can persist if sources are not addressed. Understanding the microbiology of waterborne disease is vital for both clinical management and public health responses. Any diarrheal illness among food handlers, healthcare workers, or daycare staff triggers occupational health notification. Now, a little bit about imaging indications. So, abdominal imaging, especially CT, is rarely warranted in routine diarrhea, but becomes indispensable when signs of acute abdomen appear, localized peritonitis, rebound guarding, or unexplained severe pain. Imaging can differentiate infectious colitis from ischemic or inflammatory bowel disease and reveal complications like perforation or abscess and evaluate alternative diagnoses such as appendicitis or diverticulitis. Simple plain X-ray also can detect some of these conditions, so don't forget about that. In severe or toxic presentations, especially with Clostridium difficile or Shigella, CT can demonstrate colonic wall thickening, pericolonic fat stranding, or nematosis. Toxic megacolon, a life-threatening dilatation more than 6 cm with systemic toxicity, mandates urgent surgical input. Similarly, CT can reveal extraluminal air suggesting perforation or localized abscesses, amenable to drainage. Understanding radiologic patterns supports early surgical collaboration and prevents delays in recognizing evolving complications. While CT evidence of diffuse colonic wall thickening suggests Clostridium difficile, it is not pathognomonic. Similar findings occur in ischemic inflammatory or viral colitis. Radiologic impression must therefore be interpreted alongside clinical context. So we have discussed about investigation, now about treatment. The basic principles are same: treatment of symptoms, treatment of cause, and treatment of complications, if any. Regardless of etiology, rehydration remains the most life-saving intervention in diarrhea. So, assess deficits early and correct with oral rehydration solutions or ORS in mild to moderate cases, or intravenous isotonic fluids in severe hypovolemia. Monitor urine output and hemodynamics closely. Potassium replacement may be needed due to losses in stool. Effective management begins not with drugs, but with restoring circulating volume and electrolyte balance. Once volume status stabilizes, attention should be to etiologic diagnosis. Not all identified pathogens require antimicrobial therapy. Many viral infections resolve spontaneously. Empiric or pathogen-directed antibiotics should target invasive or high-risk infections. Early recognition of Clostridium difficile, Listeria, or cholera ensures timely therapy and prevent complications. The indiscriminate use of antibiotics for non-bloody, self-limited diarrhea offers little benefit and carries risk like development of resistance, disruption of microbiome, and Clostridium difficile colitis. Similarly, anti-motility drugs such as loperamide are contraindicated in dysentery or febrile illness due to risk of toxic megacolon. So, the cornerstone of management is fluid replacement, and oral rehydration therapy is the foundation of diarrheal management and the single most effective intervention globally for reducing mortality. The physiologic principle rests on sodium-glucose co-transport. Glucose enhances sodium and water reabsorption, even in secretory diarrhea. So solutions should approximate WHO or commercial formulations containing 75 milliequivalent per liter sodium, 75 millimole per liter glucose, and homemade mixtures or diluted fruit juices can be adjuncts but lack ideal osmolarity. In mild to moderate dehydration, oral replacement is as effective as intravenous therapy and avoids complications such as electrolyte imbalance or overhydration, especially in older adults with cardiac disease. Commercial oral rehydration salts like rehydrolate or ceralite match the WHO composition, containing appropriate concentrations of sodium, potassium, and base, that is bicarbonate or citrate, to correct acidosis. These solutions outperform a sports drink or clear sodas, which are too hypotonic or hyperosmolar and may worsen diarrhea. So clinicians should educate patients on proper preparation and dosing of ORS. Frequent small sips rather than large boluses minimize gastric intolerance. The message is to emphasize evidence-based rehydration solution and saves lives more reliably than any antimicrobial in acute diarrheal illness. When patients present with signs of severe hypovolemia, tachycardia, hypotension, oliguria, or altered consciousness, intravenous rehydration becomes mandatory. Isotonic fluids such as Ringer lactate or normal saline are preferred for rapid restoration of intravascular volume. Once replete, transition to oral rehydration for maintenance. Monitor for electrolyte shifts, particularly hypokalemia and metabolic acidosis. A dehydrated gut cannot heal, nor can antibiotics reach effective tissue levels until perfusion is restored. So, what is the physiology of oral rehydration? In most diarrheal illnesses, the small intestine retains its capacity for sodium glucose coupled absorption. This pathway, mediated by SGLT1 transporter, allows simultaneous uptake of sodium and glucose across enterocytes, drawing water along osmotically. Even in cholera, where secretory mechanisms are upregulated, this co-transport remains functional. So exploiting this physiologic loophole through oral rehydration therapy turns pathophysiology into treatment. It is a triumph of translational medicine, simple biochemistry converted into life-saving therapy that has prevented millions of deaths worldwide. The absorbed sodium and glucose increase plasma osmolarity, creating an osmotic gradient that drives water absorption through aquaporins and paracellular pathways. Thus, for every molecules of glucose absorbed, multiple water molecules follow. This principle explains why balanced ORS formulation with both sodium and glucose are superior to water alone. Pure water dilutes plasma sodium and fails to correct extracellular deficits. The mechanism also underscores why sweetened beverages or a sports drink without adequate sodium content, such as soft drinks, may exacerbate diarrhea by creating osmotic load in the gut. Despite robust evidence and cost effectiveness, ORS actually remains underutilized even in resource abundant hospitals. Over-reliance on IV fluids stems from misconceptions about the efficacy or patient expectation. Oral rehydration achieves comparable outcomes in mild to moderate dehydration and can often prevent hospital admission. Now about empiric antibiotic therapy. Empiric antibiotic therapy is justified when patients have systemic toxicity like high-grade fever, volume depletion, or high stool output exceeding 6 per day. These features indicate invasive bacteria or high bacterial burden. However, empiric antibiotic must be accompanied by stool collection before antibiotic initiation to preserve diagnostic yield. Clinical severity, not patient pressure, should direct the decision, balancing benefit against risk of resistance and adverse side effects. Presence of blood or mucus in stool indicates colonic invasion, warranting empiric coverage while awaiting for microbiologic results. Similarly, high-risk hosts, older people, pregnant women, immunocompromised, or those with cardiac disease face disproportionate consequences from dehydration and infection. For these patients, even moderate symptoms merit consideration of empiric antibiotics. However, caution is required in suspected Shiga toxin producing Escherichia coli, where antibiotics may precipitate hemolytic uremic syndrome. For non-bloody self-limited diarrhea without any systemic features, antibiotic does not offer any benefit, rather increases the risk of Clostridium difficile infection and resistance of organisms. Overuse of antibiotics in these contexts perpetuates a false perception that antibiotics cure diarrhea, undermining the evidence-based practice. Now about empiric antibiotic choices. So azithromycin is the preferred empiric agent in most contexts, especially when dysentery or fluoroquinolone resistance is suspected. It covers Campylobacter, Shigella, Salmonella, and many Escherichia coli strains. Emphasize that empirical azithromycin is evidence-based, not a blanket measure, but targeted to situations where bacterial invasion or systemic illness is plausible. Fluoroquinolones are historically first line for bacterial diarrhea due to its broad activity and rapid symptom relief. However, rising resistance, especially among Campylobacter and Shigella, has reduced their utility. So fluoroquinolones now represent a context-specific, not default option. Choice of empiric agent should reflect local resistance surveillance and patient risk factors. In suspected Shiga toxin producing Escherichia coli, particularly in bloody diarrhea without fever or following outbreak exposure, antibiotics are contraindicated. Antimicrobial induced bacterial lysis releases Shiga toxin, precipitating hemolytic uremic syndrome characterized by anemia, thrombocytopenia, and renal failure. Supportive care with aggressive hydration and avoidance of nephrotoxic drugs is the mainstay. So clinicians must be vigilant. When in doubt, hold antibiotics until stool testing confirms or excludes Shiga toxin producing Escherichia coli. This is one instance where doing less actually saves lives. For confirmed Clostridium difficile infection, the standard of care is oral vancomycin or fidaxomicin. Metronidazole is now reserved for mild, fast episodes if the preferred agents are unavailable. Therapy should always be coupled with discontinuation of the offending antibiotic and implementation of contact precautions. Recurrences may require pulse taper regimens or fecal microbiota transplantation. Prompt recognition and appropriate therapy prevent progression to toxic megacolon and sepsis. Listeria monocytogenes causes febrile gastroenteritis or systemic infection in pregnant women, older adults, and immunocompromised patients. Empiric coverage with ampicillin, often combined with gentamicin for synergy, is recommended pending cultures. In pregnancy, early treatment prevents transplacental spread and fetal loss. So clinicians must maintain suspicion following ingestion of unpasteurized dairy or processed meats. This is a classic example where the host context rather than symptom severity dictates antimicrobial choice. For suspected or confirmed cholera, profuse watery rice water stools following travel to endemic regions, single dose doxycycline or azithromycin reduces stool output and disease duration. However, remember, rehydration remains the mainstay. Now about symptomatic treatment. Loperamide, a peripheral opioid receptor agonist, reduces intestinal motility and enhances water absorption. It can shorten the duration and frequency of stools in uncomplicated, non-invasive diarrhea. However, its use must be restricted to afebrile, non-bloody cases where invasive pathogens are unlikely. In febrile or dysenteric illness, anti-motility agents can exacerbate disease by retaining bacteria and toxins within the gut lumen. This will be leading to complications such as toxic megacolon. In the setting of dysentery, bloody or mucoid stool, high fever, or abdominal pain, loperamide is contraindicated unless appropriate antimicrobial therapy is already initiated. The rationale is straightforward. In invasive infections, intestinal motility serves as a defense mechanism for pathogens clearance. So suppressing peristalsis without eradicating the bacteria prolongs toxin exposure and increases complication risks. Bismuth subsalicylate exerts both antisecretory and antimicrobial effects. It is a reasonable alternative for symptomatic management, especially in febrile or dysenteric cases where loperamide is unsuitable. Its salicylate component should, however, be avoided in pregnancy or patients taking aspirin. Resicadotril is an encephalinase inhibitor. It reduces intestinal hypersecretion without altering motility. Studies suggest faster recovery and fewer adverse effects than loperamide, though availability is limited in some regions. So symptomatic agents should always complement, not replace, rehydration and etiologic treatment. Now about dietary measures. So maintain nutrition. Nutritional support accelerates mucosal repair and immune recovery. Even during acute diarrhea, patients should continue eating except if there is vomiting. Boiled starches and cereals, rice, potatoes, noodles, provide easily digestible energy and minimize osmotic load. Salt supplementation prevents hyponatremia. The bread diet, that is bananas, rice, applesauce, and toast, remains a simple, practical guideline. Caloric intake sustains enterocyte turnover and prevents the vicious cycle of starvation-induced mucosal atrophy. The historical practice of fasting during diarrhea is outdated and potentially harmful. Post-infectious lactase deficiency is common in diarrhea. It can cause secondary lactose intolerance for weeks after enteritis. So, dairy products, milk or cheese can exacerbate bloating and diarrhea. Exceptions include yogurt and fermented milk, which contain live bacterial cultures that aid mucosal healing and produce less lactose. High fat and fried foods slow gastric emptying and worsen symptoms through bile acid stimulation. So, a temporary low fat, low lactose diet improves comfort and supports recovery. Dietary counseling should be individualized, especially for patients with baseline malabsorption or irritable bowel tendencies. As bowel function normalizes, dietary restrictions should be lifted progressively. Overly prolonged restriction can lead to nutritional deficits, especially in frail or older patients. About probiotics. So probiotics are widely marketed, but its role in acute diarrhea remains unproven, even in well-conducted adult trials. Meta-analyses show minimal or no clinically meaningful reduction in duration or severity of diarrhea. Variability in strains, doses, and endpoints clouds interpretation. So probiotics should not replace standard therapy. Routine administration of probiotics for acute infectious diarrhea is not recommended by major societies. Their benefit is inconsistent and quality control among commercial preparations remains questionable. Furthermore, in immunocompromised patients, probiotics carry a rare but real risk of bacteremia or fungemia. So clinical practice should follow evidence, not marketing. Hydration, nutritional support, and selective antibiotics remain the pillars of therapy. Hydration addresses the mechanism. Antibiotics address the minority of cases with treatable infections. Probiotics, by contrast, lack mechanistic necessity or consistent outcome benefit. Probiotics may be explored in research, but current standard of care demands proven interventions, not a speculative treatment. Now let's discuss about follow-up and prevention. So most patients recover completely without further investigations. Routine repeat stool cultures are unnecessary unless mandated by occupational or public health regulations. For example, in food handlers or healthcare workers. Persistent diarrhea after clinical improvement may warrant evaluation for post-infectious irritable bowel syndrome rather than ongoing infection. Over-testing creates false reassurance or unnecessary restrictions from work. Prevention is anchored in basic hygiene. That means hand washing after toileting, before meals, and during food preparation. Safe water practices like boiling, filtration, chlorination reduce enteric pathogen transmission. Food safety measures such as cooking meats thoroughly, avoiding unpasteurized dairy, and refrigerating leftovers prevent contamination. These are simple but evidence-based steps with massive epidemiologic impact. In hospital settings, strict contact precautions for Clostridium difficile and enteric pathogens protect both patients, doctors, and staff. If symptoms fail to resolve within 3 weeks, the clinician must reconsider the diagnosis. Chronic or recurrent diarrhea may represent inflammatory bowel disease, microscopic colitis, celiac disease, pancreatic insufficiency, or drug-related effects. At these at this stage, colonoscopy with biopsy and malabsorption studies become appropriate. The transition from acute to chronic signals a shift from infection-driven to inflammation or absorption-driven pathology. We have covered different aspects of diagnosis and management of diarrhea. Please keep tuned for more contents to come and press the bell icon and subscribe this channel if you like it. So thank you everybody. Thank you for your patient hearing.